Fascinating topic on how oncologists make decisions or perhaps don't make decisions. And joining us is Geoff Oxnard, MD, clinical instructor on the faculty of the Dana-Farber Cancer Institute in Boston, Massachusetts. You've taken on a pretty interesting topic and in presenting here at ASCO. What can you tell us about it?
Well, we're studying a simple series of patients and trying to learn something big about it. The patient population we're looking at is EGFR mutant lung cancer, which is a unique subpopulation of lung cancer that is uniquely sensitive to erlotinib, Tarceva, an oral EGFR inhibitor. These patients have great responses, often durable, and they can do very well on this drug for a long time. And so we collected 42 patients who had been treated on clinical trials of first-line erlotinib and eventually progressed, and we looked at the point of progression, what happens afterwards. And we said, how often were patients continued on their drug, even though they'd progressed? How long can they stay on that drug and not start chemotherapy? Because I think we're all pretty good at talking about when do you start treatment in advanced lung cancer, but it's not quite as clear when you're supposed to switch treatment, especially with a treatment that is so uniquely effective in such a small population of lung cancer patients. So what we found is, of these 42 patients, almost half of them were able to delay receiving some other treatment, chemotherapy, for more than 3 months. And that's because they stayed on erlotinib, or maybe they received radiation, or maybe they got a treatment break. And 20% of patients were able to delay chemotherapy for over a year, despite the fact that the radiologist says they've progressed, erlotinib's not working. The clinician said, I'm not going to change course. They seem to be doing okay, and they can still stay on the drug for more than a year. This is a mild drug that they're tolerating, and it makes you think about the fact that making these decisions is more complicated than we realize. And it's not just about when does the radiologist say the cancer's progressed. It's a very personal decision for an individual patient with an individual therapy about when we can keep on going and when we need to change course.
And there are so many factors that go into each doctor making that decision. Their education, their feelings about certain things, how they view failure, and how you view change.
I think the most important in the end is the individual patient's biology. If you're treating lung cancer with chemotherapy, you're given an empiric therapy. You don't know if this treatment's going to work or not. It's fairly toxic. And when things get rough, there are a lot of things telling you to change course. They're having neuropathy, they're having nausea, they're wiped out, they're exhausted. In a treatment like that, I think we have a pretty low threshold to say, this isn't working, let's change course. But in targeted therapy, when you know that cancer is uniquely sensitive to that drug, when the drug's mild, what we're finding is that we don't need to change course as easily as we would have with the chemotherapy. We can hang on for a little bit longer. And sometimes these patients with metastatic cancer can get a lot more benefit out of a drug than we used to think.
How do you balance quality of life versus what is perceived to be failure?
It's a delicate question, especially between an oncologist and a patient talking about what do their scans show. How do you tell a patient, well, it's growing, but it's not that bad. Just hang on. I think we can get more distance out of that. Patients get very nervous about that. Patients want to say, wait, if it's growing, maybe I should do something different. And I want my research to give clinicians confidence that you don't need to change course, and that if a patient is asymptomatic, if they have slow growth on Tarceva, there's a good chance they could do okay on that drug for a while more, and give them confidence and say, let's get a little more time out of this. This is good time. This is low side effect, no symptoms. This is okay. Stay on Tarceva, and maybe we can get months or years out of this drug.
This may seem a little strange to you, but an analogy that comes to mind is sometimes it's hard to understand how firefighters do their job. And sometimes you hear about the term controlled burn, where they just let a certain area burn in order to protect something else. Is it kind of the same, perhaps a similar type of mindset that is required?
It's an interesting point. I mean, treating metastatic cancer is a marathon. We aren't trying to pile up the intensity to try to use up all our drugs right away. We're trying to get the most distance out of each drug that we have. And in a cancer like this, with unique sensitivity to this targeted therapy, what you want to do is get as much mileage out of that as possible. And you're right. We have to think about progression differently. There's mild progression, there's aggressive progression, there's symptomatic progression and asymptomatic progression. It's a more complicated phenomenon than just, yes, they've progressed or no, they haven't. And in some patients, if it's a controlled burn, if they're asymptomatic and just slow growth, you can get more distance out of that drug, high quality time for that patient, before they develop symptoms and they develop clear evidence that it's time to change course. What we don't know is when that time is. It's not clear when is the time when you need to change direction, and that's research that we need to do. What is the sign that it's time to start another treatment before things are going to get bad?
You could go in any number of directions with this research. Where do you go, or where do you plan to go?
My personal interest is broadening this observation to the rest of oncology and get cancer doctors in general to ask the question, if this person's progressed, let's figure out more characteristics of that progression. If you take a clinical trial right now and look at the data we get back from that clinical trial, the clinical trial tells us time until progression. But it doesn't tell us how many of those progression events had new brain metastases or how many of them were asymptomatic, the characteristics of treatment failure. I think we need to collect more information in our clinical trials to allow us to start answering these questions. And so I would ask that people running trials, cooperative groups, start collecting a little bit more data and start thinking about this in a little more nuanced fashion. And once we have that data, we can learn a lot more. There's a trial right now being led by Tony Mok in Asia, asking this exact question with EGFR mutant lung cancer being treated by Tarceva. Start the drug, and the goal of the trial is to see how much mileage we can get out of this drug without changing course. It's now completed accrual. We should start getting the data in the next 6 to 12 months. I think that'll be very exciting. In a prospective fashion, asking, we say time until failure on erlotinib is about 12 months from the big clinical trials. Maybe it's a lot longer if we change our definition of failure.
Very good. Best of luck to you. Thanks for joining us. Dr. Geoff Oxnard with some really thought-provoking work for all of oncology going forward. Good luck to you.
Thanks.